Okay, we'll go ahead and start. Hi, everyone. My name is Myra. I'm the program manager for the AETC here in West Virginia. Thank you for joining us today. Our session today is on the current HIV testing for 2026, and our speaker is Danyel Tacker. Danyel Tacker is a board certified clinical biochemist currently serving as clinical professor of pathology in the WVU School of Medicine, Department of Pathology, Anatomy, and Laboratory Medicine. In this role, Dr. Tacker serves as CLIA Medical Director of the Fairmont Medical Center Laboratory, Section Director of Special Chemistry and Mass Spectrometry for the WVU Hospital Laboratory, and lead for IT and technology standardization for the WVU Medicine System Laboratory Affinity Group. She is also involved in policy and external affairs work through her primary professional organization, the Association for Diagnostics and Laboratory Medicine. And then I'm going to just go through some of our disclaimers here. The ATC is supported by HRSA as well as the U.S. Department of Health and Human Services as part of an award totaling $3.2 million, 0% financed by other non-governmental sources. Contents of the authors do not necessarily represent the official views and or endorsement by HRSA, HHS, or the U.S. government. The mission of the AETC is through comprehensive healthcare, workforce education, clinical consultation, and technical assistance. The AETC program enhances the quality of HIV care outcomes for people with HIV and communities disproportionately impacted by HIV across the United States and its territories. And our vision, is to transform HIV care by strengthening systems of education, consultation, and support, advancing a unified interdisciplinary workforce equipped to meet the evolving needs of patients and clinicians worldwide. Dr. Tacker is employed by WVU. She is a member of the Medical Lab Management Board of Directors. She has no current financial relationships or NDAs to disclose. And with that being said, I'll hand it over to you.
Thank you, Myra. Hello, and thanks for the invitation to come and speak. It was a little weird for me to go, oh, I'm the one who's supposed to be advancing the slides, and I'm very sorry. So on the slide deck that you should have access to at the end of this does have those disclaimers and slides at the beginning of them. Okay, so we will get started. There's several subtopics that I have today, but the first one that I was going to cover was the current state of HIV in the United States and how it relates to testing needs. Because to understand why we have the testing we have and what it does, it's kind of good to get a quick snapshot. And I'm sure that this group reviews these sorts of things regularly. But let's just do that so we're all on the same sort of playing field here. So we're looking at the undiagnosed gap. Currently, there are about 1.2 million people in the United States that are living with HIV. About 1 in 8 are unaware of their status. So there is a giant opportunity here to try to identify the patients who fall in that gap and to try to address their needs, because we all know that the outcomes are better if intervention happens soon and is sustained. Right? So early knowledge is that entry point into having antiretroviral therapy on board, to trying to get those burdens low, and to trying to make sure that monitoring is established and continues clinically as well as in the laboratory side. So all of this stuff leads to a picture where when a patient knows their status, they have a lot of power and they are really involved in their care. And so when we're looking at testing and looking at viral loads, if it's undetectable, it's basically untransmittable, and the data have shown this for many years now. So the goal is to get person on ART early and to keep driving that undetectable trend. So then the objective here is to just take this knowledge and walk in looking at the tools that we have now to kind of close the diagnostic gap and discuss the populations that need to be treated, tested, and treated, et cetera. So first, who should be tested? That answer is going to depend on who you ask. And it depends regionally, it depends on the setting, how much training the provider has about HIV, depending on where you grew up when, HIV is either a massive killer or something that a person can live with. It's an uncomfortable conversation, or it's another infection that needs treatment. You know, the spectrum of knowledge on this is very broad. So making sure that the tools we have for providing diagnostic information needs to take into account that broad range of people and their appreciation for the disease, and also the infection, and also how we treat it. So the best way that we protect society, the best way we do the least harms and do the most good simultaneously, is to have broad screenings of all persons who basically can be sexually active or can have any kind of exposure. And generally, the 13 to 64 you see on screen is what the guidance is from the CDC. They say basically, you know, if you're in that range, you should be screened. There are others who say, well, you know what, when you're born, you should be screened to see if you have a perinatal infection. What if mom was never diagnosed? You know, what can we do? But the theory is that everybody should be tested at least once. But next line, um, consent to test is mandatory. Some sites will write this into their blanket. If we're going to treat you, your consent covers basically any diagnostic tool we need to understand your clinical picture. It gives a pretty rapid roadmap to testing in the emergency department settings, acute care settings where a patient may present and not be able to speak for themselves. It also normalizes the testing so that people don't think that they're being picked on, singled out, stigmatized in any way. It's just another part of the workup. So that piece in consent, still very important piece of care. How do you address it? How do you take care of it in real time? That can vary from site to site. Testing programs, they cost money, right? We're talking about screening for HIV in a person who may come in with a broken bone or who may come in with some other cause. And if we're looking at the very complex world of diagnostic codes and billing, to do an HIV screening test but not have a diagnosis code that plays into HIV diagnosis is probably going to get you a non-payment. So programs that provide HIV screening are walking into this game knowing that there's going to be cases where they're not paid for that work. We usually provide the test anyway, like we're going to do the test. And institutionally, at least here, we'll figure it out. But at other places, they don't have that kind of budget. They don't have that kind of capability. So variability gets introduced there too. Many places lack counseling and support infrastructures for patients with HIV. So not every place has an HIV treatment center. Not every place has an infectious diseases group that is used to these conversations. So depending on what kind of infrastructure you have institutionally, the capabilities for having these discussions can really shrink and swell depending on scope and range and setting. So what we generally agree, after thinking of all of these complexities, of all these permutations of potential complications in who are we going to test, this is what we generally say. All pregnant women with each pregnancy should probably be screened. You know, let's take a look at them. Patients with sexually transmitted infections, that HIV can move along with some of those. And so we know this. We go ahead and say some level of risk has happened because sexual activity has happened, and it's still sexually transmitted to some extent, right? So let's do that. Men who have sex with men, partners of patients with HIV, and others deemed high risk definitely should be screened. These are things that nobody argues against. What they tend to have the bigger problem with is just generalized screening. So at the bottom, we have the ones we all generally agree to. Next, moving from that into, okay, so now we're going to test people, access, cost, and confidentiality. These are the next considerations we need to make. As it says in the title here, testing settings vary, and I've already gone through some of that. But we also have more options for testing now. It's not the way it was 15 years ago. When I started here at WVU. So I used 15 years because 16 years ago, I walked in the door and started directing in this laboratory. And I remember very well what our options were then. They are not the same thing that we have today. So in clinical laboratories, there are testing options that are very broad. We have the class, it is the classical testing location for sexually transmitted and other infections. So we are a natural site for testing for diseases. The pros here are that clinical laboratories are going to be able to run FDA-approved tests. Basically, it's an easier path to offering the test. It's not overnight, but it is something that we're trained to do. We build tests all the time. We're constantly monitoring their quality. We're always answering questions about our testing. So we're kind of naturally suited to providing that service. And when we talk about the cons, time and cost are definitely with those, because with our level of expertise, with our level of automation and the equipment we have to provide to just have the testing on the menu, to hire people that can do the testing for us, to hire people like me who can answer the phone and talk to a clinician. Yeah, it's probably gonna cost more to get that HIV test from us. And because you have to get a specimen and get it to our location, and then we have to do the testing and get that report back to you, gonna take a bit longer. What I wanted to note there with that asterisk, when it comes to cost, per the Affordable Care Act, HIV testing is one of the carve-outs for a mandated no-cost coverage. Okay, so a person walks in the door and needs an HIV test, figure it out institutionally. They don't have to be charged for this test. Like, it needs to be done. It was recognized as an important thing. I haven't seen any change to that policy. So that could change, over time with various administrative policies that are launched at the governmental level. So we might see reforms to that. We might see expansions of that. We never know. And then the opposite side of this coin, and what is a little bit newer, it's not 2026 new, but it's newer, is this idea for rapid and self-testing options. These rapid tests have really come on the scene, and definitely there's been an expansion since COVID brought rapid testing more into scope. Before it was a pregnancy test is a rapid test. Occasionally you'll see drug cups at your local pharmacy / convenience location. And you could get a various number of kits. But now there's all sorts of things that people can either buy for themselves or clinics can acquire and get a governmental certificate and have a little testing program in the clinic setting. And this can be a huge win for that location because of their needs. So small clinics and urgent care settings are often offering these rapid screening options, often in tandem with our laboratory. We know this, we work with them. We even help them troubleshoot things. So it's not like this is an adversarial division between these two. It's just a setting thing. The pros of those rapid kits, as you see here, relatively inexpensive. They're approachable. You can get them, you can boop them, you can put them on your inventory in the clinic, you can have them available. As long as you use them according to the instructions and within the expiration date, you're usually pretty good to go. They can be completely private. So a person can test themselves at home in many situations, or it's just between the provider and the patient in the clinic setting, and you're both watching that thing develop together. So it's a very discreet way of doing it. Back in the day when we had to get consent forms signed by patients to do any testing, there might need to be 6 phone calls to track that patient down and get that signature. That is not PHI compliant. That's just a terrible system, and we hated that. But in clinic, face to face, most intimate way you could ever get tested and counseled about that. You can get these for free from the CDC, and a lot of people don't know this. So you're welcome. There's this program called Together Take Me Home. And if a patient has a risk profile where they might want to keep testing on site, say they have a spouse with HIV, say that they are men who have sex with men, they want to screen themselves more often in a private setting, more discreetly, and they want to monitor their own status and have their status updated regularly, they can do that at no charge. And that is a win. That's a huge win in discovery. Cons here, incorrect collection and interpretation is possible because we're talking about putting kits in the hands of people who are not laboratory trained. It's no insult, it's fact. It's just, you have to make this kit very straightforward in its use, and you have to make sure that the instructions are excellent. Literature backs this idea that you can put the kit in the hands of someone, you think it works perfectly well, and you understand everything, and the patient may still have trouble comprehending what they need to do. So sometimes the kit instructions are a little difficult. Mail-in testing can take more time than local lab testing. And so depending on where a person is putting this in the mail and where that testing lab is, there can be complications in delivering those results back. So, and then we have some performance type questions that will come up. I know that that's on everybody's mind. Which one of these is more accurate? Which one of these is more precise? We're going to get into that. Right. So that last piece was confidentiality. The central lab testing and most public health agencies will retain some sort of PHI. They usually need some level of it in keeping their records. In our charts and the requirements we have from a regulatory perspective, we absolutely have to keep our records identifiable, but behind our firewalls. So we don't try to advertise them, we don't try to release them, and we try to make sure that they are highly secured at all times. That is what we are intended to do by federal mandate. So reassure you, we aren't just disclosing people's information. Public health labs too need to at least know some basic information: age, gender, county, once they've contacted someone or made sure that some kind of testing outcome happens when a positive pops up in their database. But we are charged with being very careful about how we handle this information, as we would for a glucose or a drug test or anything else. To us, it's pretty much the same. It's all information. Some community programs are going to offer anonymous testing and counseling services. That's that one-on-one thing. They're usually going to have like a small strip test, and they're only going to report the positives if their program is geared to doing that. But the state usually wants to know if a positive is found for this and many other infections. So that's about the confidentiality. We try to do everything we can to maintain that. So that leads us finally to the testing. Spent many minutes here talking about the framework of all of this, and now we're finally up to these approaches. What we know from the technology is that our detection window has, with every generation of HIV testing, has moved back. And if we look at where we are with screening and how we flow through algorithms, which is usually from an antibody and antigen-based screening, then to viral detection if needed, because it's the most expensive test. We try to make algorithms. Each generation of testing has closed that window of discovery, which is so wonderful for trying to detect early, trying to get treatment on board early, and try to do risk prevention and harm reduction maneuvers, right? So first generation immunoassay, we're talking, this was 1990s, late 80s, because it was just when finally everything was discovered, and then they were able to start making assays to detect it, right? Then Western blots came around, and they were the definitive method that was paired with screening for a very long time, until the CDC said, you know what, the modern assays that we're getting to, their accuracy and precision is so much better that you really don't need Western blot anymore. But what you see is this window just keeps closing. First generation and Western blot out to 60 days of infection. Moved that down to about 45 days with second generation. And this was, early 2000s. Then the third generation is right here, where you're still looking only at antibodies. You're not catching antigen yet. So it takes time for a patient just to make the antibodies, right? You've got to give them time to let the immune system percolate. And if a person is infected, then you're going to start seeing dysregulation pretty soon. So, this window, 22 or 23 days, right? Then we get to fourth generation, and this is when we started combining antibody and antigen testing together. Fourth generation testing is a single qualitative result. Something is positive here, figure it out. And you're charged with figuring out if it's antibodies that are being produced, antigen that's present, both, or there's some kind of interference and it's false positive, which does happen. It's a test. Every test has its performance limitations. Then we get into these fifth gens that have gotten the window down to about 11 days. Still looking for antibody and antigen, but the difference between the fourth and the fifth generation in terms of how they're configured is fifth generation tests have a slot for HIV-1 antibody, POS-neg, HIV-2 antibody, POS-neg, and P24 antigen, POS-neg. What that enables you to do is figure out which one immediately, or if all three are present, and you can move through the diagnostic algorithm super fast. So we've gone from this combined qualitative, vague, something's here, do something, to this is what's positive, and now you know what to do from here. And what you see here is there is a little eclipse, but even with your viral detection stuff, it's still going to take a few days for the viral load to be high enough to detect. So sampling is still a question in that eclipse phase. It is always going to be there just because of the mechanics of viral infection. So it's better. It's not perfect. Nothing ever is. All right. So the tests and their uses features in the United States. In Europe, the reason I clarify this is because Europe has its own kind of agency. It does approvals differently, and they push things to market sooner and in a different configuration than we do in the United States. Asia, same way. Australasia, a whole other conglomerate, they do it another way too. But here in the US, what you see is this kind of comparison. You see the antigen and antibody combination testing, 4th and 5th gen that I just described. Here's their targets, their earliest detections, and what you see is, we're pretty good. This is the standard of care for screening because it's affordable and rapid. We can do an HIV combo test in my laboratory down the hall in 45 minutes or less. Usually it's about 45 minutes to an hour because just of motion, physics, etc. Usually about 45 minutes. So that is going to give you a pretty quick answer in my lab. In a point of care screen, it's going to be like 10 minutes to develop that, and it'll give you the same types of outputs depending on how that cartridge or test is configured, even in the point of care, like right in front of that patient. Antibody-only testing is still around, but it is the second tier of our algorithm now. So if we get a positive combo in my lab, we go over to a test. I'll just say who it is. It's called the Bio-Rad Genius test because it's the one that we have. There are others out there. So there are many options, but I'll just tell you, we use Genius. You take that serum and you now do separate HIV-1 and HIV-2 antibody tests to say, are antibodies present and which one? If you get a discrepancy, what if it was antigen that caused this to be positive? You really should get the nucleic acid amplification test as the third tier of this algorithm. So you just move from left to right depending on what you end up with. The algorithm states from the CDC that if this test is positive and then you get a positive hit on these, technically you don't need the PCR, technically. But there are some people who are supreme controllers who are able to clear virus and not get chronic infections. They will lifelong have antibody positivity and lifelong be able to suppress nucleic acid amplification and thus chronic infection. So do I recommend the nucleic acid test? Yeah, I do. Do I recommend continued screening in a patient that's already established a true positive infection? No, because for the rest of their lives, they're going to have antibody present whether or not they have virus present. So this becomes a screening. And then once you've got the diagnosis, monitoring is on the right side. Okay. You see the detection days and then these uses here at the bottom. But really, these options, I don't split out point of care from central lab. The reason for that is that they're available in both settings now, and they perform about the same. We can't always say that about point of care testing, but this is true. In this case, it is. I already talked about this really, how the 4th generation screen has that one true combo test. It's qualitative. And the 5th generation gives you the 3 separate results. And then here's how you move through it. And I've already talked about that too. So when you get the slide deck and you want to, peruse, or you want to remind yourself, here it is for you in a summary format. And then here's the example of the algorithmic approach that was proposed by the CDC. It is still the current algorithm. I checked this just a few weeks ago just to make sure it was still the one that was posted because sometimes guidelines get updated and it takes us a little time to find them. But it is still looking exactly this way, that if you do these things, this is how it goes. So our algorithm and the one that I've described here is compliant with that CDC guideline. And you can do it with point of care or central laboratory testing for the first part. Nucleic acid still going to be in a laboratory in most cases. I haven't heard of a point of care HIV PCR test at this point. Okay, so taking these test results, pulling them back in, circling back around to clinical care. And we're getting close to the end here. The clinical context absolutely matters. So CDC, and like I said at the very beginning, we're coming full circle. There's so many people out there that say do universal screening. Philosophically, I can totally agree with that and embrace that. But practically speaking, clinical risk assessments still happen. It still does. It is a very important factor in interpreting screen results because there are certain populations that kind of repeatedly come back with false positive antibody tests. And then we have to sit as laboratorians and clinicians together and go, okay, are we just going to do viral load testing on this particular patient because we know there's something in their blood that is giving us this false positive test, and it's freaking them out. They're like, what's happening? Is something going wrong? Do we just go ahead and do PCR on them? How do we manage this situation? So always doing the clinical risk assessment and staying on top of that and looking at the results through that lens, very, very, very important. Reactive and positive screening findings are presumptive until some kind of follow-up happens, or you repeat it, or the PCR comes back positive. You've used another test to confirm it. You've got to move through this before you just go to the patient and counsel them, which is why we try to work together on how these algorithms should be released, when we should call people and tell them, okay, we've got a positive result. How cautious do we want to be, or do we want to be as quick as possible? There are pros and cons to each approach to that. If you've got a non-reactive or a negative screen, you do still need to consider that in terms of the eclipse window. If you've got a person who's high risk, or they're coming in going, I think I might have been exposed to HIV, and the negative comes back, it's like, well, when do you think you were exposed again? Because there is this eclipse window, and we might need to retest you just to make sure, keeping that in mind. The CDC has this Get Tested locator so that you can make sure that patients have access to testing. And like I said, there's also that testing program where CDC will ship kits to patients for free. So definitely making sure that people have access, depending on their risk profile, is still going to be very important. So basically, patient is not going to have one visit relating to HIV testing. They're not just going to come in and say, think I've got an exposure and we're done. And I know people on this call can appreciate that because it takes follow-up monitoring, everything, even if you get a negative screen the first time. So we are to the end here. I have my wrap up with a summary slide. So the points I really wanted to drive home, and I hope I've done this, but I welcome questions. First, while HIV screening practices should be very broad, there are opt-out and risk-based policies that remain common. And we need to be mindful of that. We need to respect autonomy and make sure that we're doing things ethically. Fourth and fifth generation screening methods are readily available. They combine the antibody and antigen tests into the best detection window that we can get with the screening test. So it has improved our diagnostic capabilities, and it does perform well. If we're talking about false positives at my site, I do about 3,400 HIV screens per month, and about 2 or 3 come up positive because our population actually has a pretty low positivity rate. And usually it's about a 50-50 split on the antibody test is negative on follow-up, or it's positive. So some of them are already known cases. It's just a blend, but it's a very small bit for us. Every site needs to look at its performance in a similar way and know what its false positive rate is so that they can talk to clinicians about it. Nucleic acid amplification testing is definitive. It's going to tell you if there's virus, right? But you still have an 11-day or so eclipse window. Got to keep that in mind. Testing options are expanding, so you always have to think about what those options are, how they benefit or might limit care whenever they're chosen, and just be very careful in choosing. And be sure to talk to your local laboratorian if you need help, because we are happy to help. We would rather people not get frustrated before they reach out to us. And finally, clinical context is virtually everything here. You really need to see the patient as a bigger picture and not just zero in on that testing and then, take it as gospel. The testing can vary, and there are little loopholes here and there that people fall into. Right, so thank you very much again for the invitation to speak. And for any questions you have, I'm going to advance one more to show the references I have here. I have a bunch of links to the CDC's morbidity and mortality weekly report and several really good references that I found while I was putting this together. I hope that they are helpful to you. And